Hello everyone and welcome. Greetings from St. Louis, Missouri and the home of the Missouri Institute of Mental Health. My name is Tom Pansella with MIMH. Thank you for taking the time to join us today. We're joined by Melissa Hensley and she's going to be presenting Working with Consumers to Navigate Medicare Part D. In just a moment we'll let her take control of the program. But for those of you who are joining us for the first time, welcome. Those joining us again, welcome back. If you'd like to ask questions at any time during the presentation, please click on the Questions for Speaker link underneath the video window. You'll be able to type an email to us with your question or comment, and we'll ask those questions or submit those comments on your behalf. You can also see Melissa's slides in a pop-up window if you like. There's a link that says Speaker Slides underneath the video window as well. You can pop those up and scroll through them on your own, or they'll be visible to you in the video window if you're following on video. If at any time you would like to purchase CEUs for today's program, CEUs are available for $10. There's a CEU application link. There's also a link to the Department of Mental Health's Spring Training Institute program, at which Melissa is going to be one of our expert presenters. She's going to be on a panel there on an Ask the Expert panel, and she'll be talking about a similar topic to today's presentation. So now I'd like to introduce Melissa Hensley to you. And she is a clinical social worker and a doctoral candidate at the Brown School of Social Work here in St. Louis. She's a prior recipient of a National Institute of Mental Health Pre-Doctoral Fellowship, as well as a past participant in the Washington University School of Medicine Pre-Doctoral Interdisciplinary Clinical Research Training Program. She's just landed a job as an assistant professor of social work at Augsburg College in Minneapolis, Minnesota. She'll start that in the fall. Her clinical and research interests focus on adults with severe and persistent mental illness and the effect of changes in healthcare policy on their well-being. She spent 5 years as the group home director at Places for People Incorporated, where she worked with adults with schizophrenia and other severe psychiatric disorders. Her dissertation research centers on the impact of the Medicare prescription drug program on adults with mental illness. Melissa, thanks for joining us.
Thank you.
And the floor is yours.
Thank you. Okay. Well, the title of my presentation today is Working with Consumers to Navigate Medicare Part D. And many people have found that it is a process of navigating. It takes a little time and energy on the part of both mental health workers and consumers to get through this program. So we're going to talk about how we can make that process a little bit easier. So why would a social worker talk about Medicare Part D? After all, how much do social workers really get involved with prescription drug programs? And that's a very interesting question. And what we have found is that since this program began operation in 2006, it's created a lot of hassles for community mental health workers. The other aspect of this program is, however, that it's created access to medications for a lot of individuals who didn't have access to their medications prior to this benefit. So what we're going to talk about today is what role do community mental health workers play in this program, and what can we do to improve the experience that people have with this program, both community mental health workers and the consumers who use the program. So this next slide is just an outline of the topics we're going to be covering. First, I'm going to talk a little bit about what Medicare Part D is, for those of you who may not be familiar with the program. We're going to talk about how many people are affected by this program and who those people are. We're going to talk about the changes that took place when Medicare Part D took effect in January of 2006. We're going to spend a lot of time talking about the role of the community mental health worker in ensuring access to Part D for individuals with severe and persistent mental illness. And then we're going to discuss some of the basics that case managers and consumers need to know to make this program work well for them. And then at the end, I'm going to share some web resources and some other resources that community mental health workers can use as they're trying to gain information about this program and help consumers to get what they need. So what is Medicare Part D? Those of you who are familiar with the Medicare program know that there are several parts to this program. There's Medicare Part A, which covers inpatient hospitalization. There's Medicare Part D, which is the prescription drug benefit, and then there's B and C as well. So Medicare Part D is the prescription drug benefit. And it's the first time that when this benefit began, it was the first time that the Medicare program had a prescription drug benefit. So it was a big deal when it was passed. And it was created by a law called the Medicare Modernization Act, which was passed by Congress and signed by President Bush in 2003. It took a few years to get the program off the ground, so the program began to be implemented and people started receiving their prescription drug benefits through the Medicare program starting in 2006. One of the things that we've discovered about this program is that the rules and expectations for the Medicare Part D program are quite different from those that existed under the Medicaid prescription drug benefit. So for dually eligible beneficiaries, those people who were switched when Part D took effect from a Medicaid prescription drug program to a Medicare prescription drug program, there were a lot of changes. So we're going to talk about some of those. So why is Medicare Part D such a big deal? One reason is that there was a lot of political upheaval when this program was passed in 2003. And a couple of reasons for that. One is that this program is administered quite differently from the other parts of the Medicare program. Medicare Part A and B, which cover outpatient and inpatient benefits, are administered by the federal government in sort of a centrally located way, whereas Medicare Part D is administered by multiple prescription drug plans. And states can have as many as several dozen Medicare Part D plans from which beneficiaries can choose. And that's a very different structure. It was felt politically that that was more feasible at the time because it would introduce an element of competition and hopefully some good prices for prescription drugs through that program. We haven't yet seen whether or not that's really happened, but that was the theory. Another reason that Medicare Part D has been a big deal politically is because of the donut hole. And that's that gap in coverage that occurs after a person has incurred a certain amount of prescription drug expenses and until they reach what's considered a catastrophic level of out-of-pocket spending for prescription drugs. Fortunately, most beneficiaries who have a severe mental illness aren't too affected by the donut hole, that gap in coverage, because they have the extra help that the federal government provides to people with low incomes, and so they're not affected by the donut hole. But for a lot of elderly beneficiaries and beneficiaries with mental illness who have somewhat higher incomes, the donut hole has been a big deal, and it's created kind of a problem. Advocacy groups who deal with the Medicare program predicted a lot of problems with the Medicare prescription drug benefit. It was predicted that a lot of folks were going to end up in the hospital, that there were going to be a lot of ER problems, people coming to the emergency room because they couldn't get their medications under Medicare Part D. And there were some reports written that had really scathing indictments of the Medicare prescription drug program saying, you know, this is never going to work and people with mental illness are not going to be able to get what they need. There is some evidence from studies done of psychiatrists that indicate that some people with Part D have experienced some problems with their benefits. Joyce West and a team of researchers from the American Psychiatric Association Research Institute have surveyed psychiatrists and asked them about medication access for their dually eligible beneficiaries and have found that some people have experienced some problems. What my research has found, though, looking in the St. Louis area at community support workers who work with people with mental illness and the beneficiaries themselves, is that the transitions that have occurred because of the Medicare Part D program and some of the unique idiosyncrasies of how Part D works have been made a lot easier to manage by the fact that people have support from pharmacists in the community and from mental health workers, community support workers, other case managers who work in the community with people with mental illness. And so the Medicare Part D program has been made a lot easier by the fact that professionals have been involved in helping people navigate this program. So who uses Part D? And the answer to that question that a lot of people don't realize is that many people with mental illness use Medicare Part D. Sometimes when I talk to people about Medicare Part D, they ask why someone who's interested in mental health would be interested in this benefit because they say, isn't that for elderly people? But the fact is that many people who have a disability related to mental illness are using the Medicare Part D program for their prescription drug benefits. And if you look at the Medicare program as a whole, about 29% of Medicare beneficiaries have a cognitive or mental impairment that causes them disability. If we look at lower income Medicare beneficiaries, that percentage becomes even higher. And approximately 34%, just a little over a third, of dually eligible Medicare beneficiaries, those who receive both Medicare and Medicaid, have a mental illness. So how many people is that really across the country? That's about 2 million people, a little over 2 million people with mental illness across the country who were switched from Medicaid prescription drug coverage to Medicare Part D prescription drug coverage in 2006. So what we see from this is that Medicare beneficiaries who have low income are more likely to be affected by mental illness than those with higher incomes. And therefore, the issues that are related to challenges that dually eligible beneficiaries may face are especially important for case managers to consider as they're going about their work with individuals with mental illness. Next, I want to talk a little bit about some of the changes that took place in January of 2006 when the Medicare prescription drug benefit took effect. What happened was that dually eligible beneficiaries were randomly assigned to what are called benchmark plans starting in the fall of 2005. What is a benchmark plan? Benchmark is the word that the Center for Medicare and Medicaid Services uses to describe a plan that's fully covered by the low-income subsidy. So dually eligible beneficiaries, those folks who are fortunate enough to be fully covered by the low-income subsidy, were assigned to those benchmark plans. There was really no rhyme or reason to the assignment of plans. It was pretty much done randomly. And then the Part D plans took effect on January 1st, 2006. So at that point, people stopped being covered by their state-level Medicaid benefits and began coverage with the Medicare Part D program. And as I mentioned before, Part D plans are privately administered by several different insurance companies, and they're the large insurance companies whose names we hear a lot. Aetna is one of them. Community CCRX is another Part D plan that's in the St. Louis, Missouri area. Blue Cross Blue Shield networks around the country have sponsored Part D plans. So Part D plans are privately administered by these insurance companies, which is a contrast to the state-administered Medicaid program. One little problem that did happen when Part D took effect was that there were some communication issues. When you're switching over that many beneficiaries, millions of beneficiaries, from one program to another, you're bound to have some communication problems with physicians, pharmacists, and beneficiaries. Pharmacists tended to be more in the loop than others. Pharmacists tended to have online access to be able to figure out what plans their clients participated in and to be able to get that insurance information more easily. Physicians did not have the same access to good online information as pharmacists did related to the Part D benefit. And a lot of beneficiaries had trouble getting the information that they needed at the time that the benefit took effect. Another communication problem that took place early in 2006, and that has continued somewhat, is that because Part D is administered by private insurance plans, there's a significant amount of advertising that goes on between the different plans. And there was quite a bit of aggressive advertising by Medicare Part D plans as well as Medicare Advantage, those Part C managed care plans that offer prescription drug benefits, to consumers with mental illness. And some beneficiaries didn't understand the nature of those managed care plans or the comprehensiveness of the benefits that they were signing up for. And some of the plans, in some ways, kind of took advantage of some of those beneficiaries. And I know of some participants in the St. Louis area who did end up in Medicare Advantage plans that were not well suited to the nature of the health issues that they were facing. So that was somewhat of a problem. In some cases, beneficiaries were not notified of their plans, and so they didn't know what prescription drug plan they were in until they went to their pharmacist and their pharmacist looked it up for them. Another issue is that everyone sort of assumes that pharmacists and physicians are the folks who need to know about this benefit, but the fact is that social workers and community case managers have also played a very important role in negotiating this benefit. But because people didn't really realize that, there wasn't a lot of communication to community case managers unless it was initiated by the client. And in some cases, clients did bring their Medicare information to their case managers so that they could get help interpreting it. But that really didn't happen. It was not initiated by the Medicare program. It had to be initiated by the client, him or herself. The interesting thing is, though, that pharmacists and case managers, actually in my research, have reported fewer problems than they anticipated with the Part D benefit. They have said that for the most part, even though there have been these gaps in communication and some little hiccups when the program started up, that for the most part, they have found that people have had fewer problems in getting what they need from this program than what were anticipated. So what were the transitions for beneficiaries? The beneficiaries who participated in my research reported very few lapses in coverage. Most of them were able to take their information about their new Part D plan, or they were able to take their Social Security card to their pharmacist and find out what information they needed to know about the plan that they were enrolled in. And as I mentioned, most pharmacies were able to access plan and benefits information online. And for participants who were dually eligible, they were automatically enrolled in a Part D plan. They did not have to worry about the process of signing up for a plan. They were automatically enrolled. Now, in some cases, people may have wanted to switch from one plan to another so that they had a formulary and a plan that met their needs. But for many people, the plan that they were initially assigned to was adequate to meet their needs. For participants in the Medicare program who were not dually eligible, whose incomes were a little bit higher, who may still have been receiving extra help from the government, but who were not considered full dual eligibles, the transition to Medicare Part D was better for them, but it was also a little bit harder. The reason it was better was that for these folks who were not eligible for Medicaid, this may have been the first time that they had a government program helping them cover their prescription drug expenses. So that was definitely a good thing, that they were getting those prescription drug benefits for the first time. However, people with those higher incomes who were not full dual eligibles were not automatically enrolled. So they had to sign up for a plan, and they also had to sign up for the extra help that they were receiving from the government. And for some clients with mental illness, that process of signing up was difficult, partly because in many cases they had to do it online, and in many cases because the paperwork was somewhat difficult to understand. So what are some of the differences between Medicaid and Medicare? As I've mentioned, Medicare Part D plans are privately administered by insurance companies, which is a big change from Medicaid. Dually eligible beneficiaries are automatically assigned to plans with low premiums that are fully covered by the government subsidy. One difference between Medicaid and Medicare is that Medicare Part D plans have different formularies and different pharmacy networks. Under a state-run Medicaid program, there was pretty much one formulary that was used statewide to determine whether or not prescription drugs were going to be covered under the Medicaid program. Pretty much most pharmacies on the state, in a particular state, would accept the Medicaid benefit because it was so widespread. With Part D plans, that's a little bit different because there are so many plans. Formularies can differ from one plan to another, and a medication that may be covered under a certain Part D plan may not be covered by another plan. Pharmacy networks are also different in some cases. There may be one community pharmacy that accepts a particular Part D plan, whereas another community pharmacy may not accept that plan. That's different from Medicaid, under which almost every pharmacy accepted the benefit. One thing that a lot of folks are not aware of is that beneficiaries who are dually eligible, who have that full coverage from the government of their Part D benefit, they may actually change prescription drug plans as often as once a month. So if they're in a plan that is not meeting their needs, it's fairly easy for them to switch plans into something that's more suitable. Now, the process of getting information about the plan may be a little bit trickier, but the actual process of switching can be done as often as once a month, which was something that advocates really fought for these beneficiaries so that they would be able to access what they needed from their plans. Beneficiaries who are not full dual eligibles do not have that option, and they can only switch plans during the annual Part D enrollment period in the fall of the year. One difference between Medicaid and Medicare as well is that co-payments, at least in the state of Missouri, were lower under the Medicaid program than they are under Medicare Part D, and I believe that's true for many other states as well. In the state of Missouri, a co-payment for a Medicaid prescription tended to be anywhere between 50 cents for a generic medication to about $2 for some brand name medications. That's in contrast to Medicare, where co-payments can be over $5 per prescription for a brand name prescription. Now, that doesn't sound like a lot of money, but for someone who relies on Social Security disability or supplemental security income for their income and only gets an income of several $100s a month, having several prescription medications with a $2 to $5 copayment can add up and can really cut into that person's spending money. So those copayments have been a little bit of a concern. One good thing in the state of Missouri with the Medicare Part D program, though, is that unlike the Medicaid program, where there's a spend-down requirement for people with higher incomes, where they have to incur medical expenses in order to have their prescription medications paid for, with the Medicare Part D program, there is no spend-down. So people may be paying copayments and they may be paying a small premium, but they don't have to worry about racking up medical bills in order to have their monthly medications paid for. So that has been a good thing for a lot of people. Next, I want to talk about some of the issues that consumers have had with Part D. The thing that's very interesting is that most consumers are actually quite satisfied with their Part D benefits, and they feel that they have gotten what they needed. And that's been a good thing that we've discovered in my research. It's always nice to see that the government is doing something that people like. But there have been a few issues that consumers have faced, and that community case managers have played a key role in helping people to negotiate. One of those things that I mentioned was that some Medicare Advantage plans have had some sort of fraudulent and predatory advertising, where Medicare Advantage plans have reached out to people with mental illness and tried to encourage them to enroll in those Part C managed care plans, when in fact the person had a number of chronic illnesses that made a managed care plan not very suitable for their health care needs. And some people have ended up in plans that were really not to their benefit financially. There's also been a little bit of confusion over plan switching and plan advertising. There's been some formulary confusion. Some consumers have had a difficult time determining whether their medications were covered under the plans to which they were assigned. Now, the Medicare.gov website has a very nice feature called the Formulary Finder, where a person can enter the prescription medications that they take into the Formulary Finder, look up which drugs are covered under their particular prescription drug plan. However, because that information is online, it's not accessible to a lot of the people that we work with as community mental health workers. A lot of people out in the community who receive mental health services are fairly computer literate, but because they're low income, they may lack internet access, and they may not be able to get on the internet and look things up on the Medicare website that would be fairly accessible for a case manager or a professional at an agency. Another issue that has been a little bit of a problem for consumers is that some Medicare Part D plans have used some strategies for cutting costs called utilization management. Probably the biggest one of these that has created issues for some people is quantity limits. There are limits for some medications, particularly brand name medications, on the number of pills that a person can obtain per month under many Part D plans. So a person may be limited, for example, for a certain antidepressant medication to obtaining 30 tablets per month. So they can take one pill a day. Now, if their physician prescribes a prescription for them in which they have to take 2 pills a day, that additional 30 pills per month may not be covered by their Part D plan. That has been a little bit of a problem for some beneficiaries. I've heard some people say that they've had to get samples and use other strategies to obtain the remainder of their medications. But for most consumers, the issue of quantity limits and utilization management tools has not been too much of a barrier to access to the medications that they need. Now, what are some of the things that have gone okay for consumers? Because as I mentioned, many of the consumers that I talked to mentioned how very satisfied they were with the services that they were getting from their prescription drug plan. One thing that has happened is that higher copayments have not been too big of an issue. For some folks who have many of those $5 copayments and who have a very low income, that can cut into their monthly spending money quite a bit. However, many of the community pharmacies that work with many of these mentally ill beneficiaries waive the copayments for these prescriptions. There is no requirement in the Medicare Part D law that pharmacies charge the Part D copayment. They are allowed to waive it if they wish. That does cut into their profits, but many community pharmacies, because they want to maintain their clientele of people with mental illness, have opted to waive copayments for low-income beneficiaries so that they can get the prescriptions that they need without the extra expense. Another aspect of this program that has made it less burdensome for consumers is that some beneficiaries have been able to enroll in the State Pharmaceutical Assistance Program. In the state of Missouri, that's called the MoRx program, and it's a program that cuts part of the payment that a person has to make for their copayment. It can cut off up to half of the expense of the copayment that a person has to pay for their Medicare Part D prescriptions, and that has been a big help. For example, if someone has a $5 copayment and they're enrolled in the Missouri State Pharmaceutical Assistance Program, they would have a copayment per prescription of just $2.50. Another thing that has worked well for many of our beneficiaries that we work with who do have mental illness is that there's good coverage under the Medicare Part D plan of these psychotropic medications. There's a regulation in Medicare Part D law that states that all Medicare Part D plans must cover all or substantially all of several different classes of medications. And included in those medications for which all or substantially all must be covered are anticonvulsants, which are used as mood stabilizers, as we know, antipsychotic medications, and antidepressants. So people who are taking those medications can usually get what they need regardless of the Medicare prescription drug plan that they're in. Now, there have been some issues. We know that a lot of people with mental illness have medical comorbidities. And for some of the brand name drugs for conditions such as high cholesterol, diabetes, high blood pressure, etc., there may be issues in coverage under formularies from one plan to another. But as far as those mental health medications are concerned that so many of the consumers that we work with use quite extensively, the coverage of those medications has been quite good. Another good aspect for consumers of the Medicare Part D plan is that almost all generic medications are covered by almost all plans. If a medication has gone generic, the vast majority of the Medicare Part D plans are going to cover that medication. Some consumers do have situations where they cannot tolerate a certain kind of generic medication where they need to take the brand name. That may create some coverage issues, but for most people, taking a generic formulation of a particular medication has not posed too much of a problem, and people have been able to get the generics that they need from the plan that they're covered by. Also, with the benchmark Part D plans, those plans that are fully covered by the low-income subsidy, most pharmacies are willing to accept those benchmark plans. So there hasn't been too much of an issue with differences in pharmacy networks from one benchmark plan to another. Most pharmacies are willing to accept those low-income subsidized plans. And again, there has been a lot of help for consumers, both from community case managers at community mental health centers and from pharmacists working at pharmacies in the community. And we found in my research that the local independent pharmacies have really offered a lot of help to people in interpreting their Part D benefits and helping them get the medications that they need. But what I've also found in my research that's been very interesting is that the chain pharmacies as well also often provide a lot of useful information to people about how to select a plan and how to use a benefit plan once they're enrolled. So both the chain and the independent pharmacies have played a really big role. So what kinds of help do mental health consumers often need with their Medicare prescription drug benefits? This is a question that I asked my research participants. What kinds of services would help them to access their medications more easily? One answer that many people gave was that they could use help with the paperwork from Medicare and from the Part D plans. Because Medicare is a government program, of course, there is a lot of paperwork associated with it, and a lot of the Medicare beneficiaries get a monthly statement from their Part D plan that they may have trouble interpreting by themselves. And so a lot of the beneficiaries that I spoke to actually liked to take the statement that they got from their Part D plan, go into the office of their case manager, and have their case manager sit down with them and help them interpret what it had to say about their out-of-pocket spending for medications and the benefits that they were eligible for. And just that simple act of sitting down with the statement and helping the person to interpret what the statement meant and what it meant for their coverage was very helpful. Again, help negotiating the Medicare website is very important. A lot of folks with mental illness have computer literacy skills, but they may not have access to a computer. So I talked to a lot of case managers in my research who sat down with beneficiaries side by side at the Medicare website and helped them to negotiate the formulary finder and helped them to go through the plan of perhaps switching from one plan to another if that was needed. That's related to the next point, which is help with plan switching. Helping consumers to determine, does the formulary of this plan fit the needs that I have for medication? Am I taking a medicine for pulmonary disease or high blood pressure that's not going to be covered by my plan? Or can I find a plan that's going to cover those medications so that I can get what I need? Going online with a consumer and helping the consumer to find out that formulary information can be extremely helpful. Also, information about how to switch from one plan to another. A lot of people do use those online resources to switch from one Part D plan to another if the switching process needs to take place. And consumers may need help with that process so that they can get that accomplished. Another thing that many consumers that I spoke to mentioned was that there were other kinds of more practical assistance that they used from their community case managers in accessing medications. And I want to emphasize how important that help was to them. Help obtaining medications, actually getting the medications to the beneficiary from the pharmacy, and help filling medicine planners to make sure that the person had their doses of medication in their medicine planner for the week or for the month. Those services that community case managers were providing in the state of Missouri were very helpful and helped people to stay on their medicine regimen and to stay adherent to their medications. So as we can see, community mental health workers play a very important role in the Medicare Part D program. They're an essential link to people in accessing the Medicare prescription drug benefit. Julie Donahue, who's a researcher at the University of Pittsburgh, as well as other researchers, have shown that many consumers would not be able to use their Part D benefits and would not have access to their medications if they did not have help from a case manager in the community at a mental health agency. We've also found that pharmacists provide much needed help to beneficiaries in interpreting their Part D plans and obtaining the medications that they need. Another thing that pharmacists often do is that if a physician prescribes a medication which is not on the formulary of that person's Part D plan, the pharmacist can often negotiate the process with the physician of getting a drug prescribed for that person that is on formulary that will do the same job. So without assistance from community helpers, many beneficiaries would not be able to get their medications. There are a couple of reasons for that. A part of it has to do with the fact that there's a lot of instability in the lives of many people with mental illness. We do our best as community mental health workers to try to minimize that instability and to try to help people have more stable lives. But often there is instability, such as changes in residence, people moving from one apartment or one group home or one facility to another. Hospitalizations can often create some instability if people are going in and out of inpatient care. And also, people with mental illness may have cognitive impairments or issues with literacy that make effective access to benefits very difficult. Those stability issues and those issues with health literacy are things that case managers can really help pave the way towards creating a more access for people to their benefits. So case managers really help when people transition from one apartment to another or transitioning in and out of inpatient care. Having a stable case manager in the community who can help smooth the way for that process is very helpful to people who have severe and persistent mental illness. So what are the basics that consumers and case managers need to know about this program? First of all, for people who are dually eligible for Medicare and Medicaid, Medicare will be their source of coverage for their prescription drug benefits. Some of the beneficiaries that I talked to still were not quite clear on that and said that when they went to the pharmacy, they would take their Medicare card, their Medicare Part D card, and their Medicaid card, present them all to the pharmacist and say, you figure it out. Well, it's important for consumers to know that Medicare Part D for dually eligible beneficiaries will be their source of prescription drug coverage. The exceptions to that would be a few classes of medications which for political reasons the Part D plan does not cover. And those include certain anxiety medications such as benzodiazepines and barbiturates and certain prescription vitamins. And in most states you can still get those medications covered by the Medicaid benefit. Another basic that consumers need to know is that Medicare Part D is administered by private insurance plans. Beneficiaries may be auto-assigned to a plan, but they may need to choose a plan that has a better formulary for them if they're taking many different kinds of medications. Another basic that's important for consumers and case managers to know is that people who are dually eligible for Medicare and Medicaid automatically qualify for what's called the Extra Help program to pay for their medications. And Extra Help is the phrase that the Medicare program uses to describe the subsidy that's provided to low-income people to cover the cost of the Medicare Part D plan. So people who are dually eligible for Medicare and Medicaid are not affected by the donut hole, and their premium for their Part D plan is fully covered by the government. For higher income beneficiaries, and that would include people whose income is up to 150% of poverty, they are also eligible for Extra Help on a sliding scale from the government, but it's not an automatic process, so they may need to apply to Medicare in order to get that. And there's been some research to indicate that a lot of those folks who are not full dual eligibles, but whose incomes are less than 150% of poverty, may not be getting the full amount of extra help that they qualify for. So case managers can play an important role with people in the community who are on the Medicare benefit, but who may not be fully eligible for Medicaid, to get the extra help that they qualify for under the Part D program to make sure that the premiums and the copayments are more covered by the government program. Another thing, as mentioned earlier, is that dually eligible beneficiaries can switch plans as often as once a month if they need to in order to find a plan with a formulary or a pharmacy network that's more suitable for the medications they take and for the pharmacy that they use. Another basic for consumers and case managers to know is that consumers should keep track of statements that are sent to them by their prescription drug plan. Some of the case managers that I spoke to in my research mentioned that they had some consumers who were afraid to hold on to this paperwork because they feared identity theft, and they were afraid that that paperwork would somehow be used to their detriment financially, and that their identity would be stolen. But it is important for consumers to keep track of these statements in a safe place if possible, so that they have the information that's sent to them by their prescription drug plan. And the reason for that is that it can help them track what their plan covers and what their plan doesn't cover, and it can help them track out-of-pocket costs, which can be very helpful. Another basic for consumers and case managers to know is that most pharmacies, as I mentioned, accept most of those benchmark fully subsidized plans. But if a consumer has a preference for a particular pharmacy in the community, he or she may want to double check with that pharmacy to make sure that their prescription drug plan is accepted by that particular pharmacy. That's important to know. So what can case managers do? There are a number of things. One thing that case managers, in my research, have done an excellent job of is becoming familiar with the www.medicare.gov website. That is an excellent resource for case managers to use because it has the formulary finder, it has access to a lot of PDF publications and other documents related to the Medicare prescription drug benefit, and it has a lot of basic information about how to sign up for the Extra Help program, which subsidizes Part D, and how to get people enrolled in a plan that's suitable for them. So all of that online information is extremely helpful to case managers in working with their clients. And it can also be helpful for them to introduce to consumers so that if consumers want to look that information up for themselves, they can do so if they have access to a computer. Another thing that case managers can do is to become familiar with the other Part D websites. And I'm going to talk some more about what some of those websites are that have information about the Part D program, how to sign up, how to switch plans, how to choose a plan, those kinds of issues. And there's actually an excellent website called www.mentalhealthpartd.org, which contains a lot of resources that are specific to the needs of beneficiaries with mental illness who are enrolled in Part D. And what I discovered in my research was that a lot of the community case managers that I talked to did not have awareness of that website, and I thought that was very unfortunate, and I was kind of trying to spread the word. This is a great website for people to use. It can also be helpful to go over paperwork with consumers, as I mentioned, that process of sitting down one-on-one with a consumer and going over some of the paperwork, and helping consumers to distinguish between what is a statement from a Part D plan, or what is policy information from a Part D plan, and what is advertising that's coming from a Part D plan. Because sometimes that can be a difficult differentiation for consumers to make. They may have a hard time telling what is some legitimate consumer information about Part D that I need to read and be familiar with, and what is an advertisement for a Part D plan that I can throw in the recycling bin. It's also important to help consumers understand formulary changes and to ensure that consumers' medications are covered by their plans. And again, that can be done either by accessing the Medicare.gov website or by calling the 1-800-MEDICARE phone line, which a lot of case managers also use. Case managers can help consumers to go over their monthly statements and track their spending. That can be a very important service for consumers. Case managers also play an important role in collaborating with other providers and pharmacists to ensure that prescribed drugs are on the formulary of that beneficiary's Part D plan. I know when I was working in community mental health, I spent a lot of time talking to physicians and to pharmacists to make sure that people's medications were covered. And that's a service that community case managers can continue to do, and that is extremely helpful, because negotiating that communication among the different providers can oftentimes be easier for that community case manager to do than for the mental health consumer to navigate all by him or herself. Another thing that I think community mental health agencies could really play an important role in initiating would be to provide more computer and internet access to consumers at clubhouses and drop-in centers. I know here in the St. Louis area, there are a number of psychosocial rehabilitation agencies which do provide a computer lab to their clubhouse members, where people can go in and do work on the computer, including getting online and surfing the internet. And that's a very important service for consumers. Some consumers do use public library resources to access the internet and to get online, and they go to the library and do that. But having those resources available at a psychosocial rehabilitation clubhouse can be a very important service. So I'm going to wrap up by talking about a few of the resources that are available with the Medicare prescription drug program for people to use. Most of these are web resources. A few of them are phone numbers. One would be the Medicare.gov website. Again, that is like central office for the Medicare program, that Medicare.gov website. You can get a lot of Medicare publications, use the formulary finder, look at different plans, look up eligibility requirements for the Medicare program. And that 1-800-Medicare phone line is also a resource if you want to call up and talk to a customer service representative about the Medicare program. I have heard some consumers say that when they've called 1-800-Medicare that they have had some problems with being kept on hold for a length of time. But I think that the Social Security Administration has been working pretty hard to try to make sure that people don't have to wait a long time on hold when they call the 1-800-Medicare phone line. So that is a resource. Another resource is the Missouri Claim Program. Missouri Claim stands for Community Leaders Assisting the Insured of Missouri. And Missouri Claim is a state-funded program that provides information to Medicare beneficiaries, unbiased information to Medicare beneficiaries about the Medicare program. And Missouri Claim is a really good resource for people working in mental health, but a lot of people are not aware of it. Most of the case managers that I talked to in my research had not heard of the Missouri Claim Program before. And the Claim Program has done a pretty good job of reaching out and providing Medicare information to area agencies on aging, as well as to hospitals and agencies that serve people with physical disabilities, but they haven't done a lot of outreach to mental health agencies. So Missouri Claim, I think it would be really good if some mental health agencies could link up with this organization to provide counseling and information to people about the Medicare program. This is a program that exists, I think, in almost every state under the title of State Health Insurance Assistance Program. So if you don't happen to be in Missouri and you're watching this broadcast, you can look up, you can enter into a search engine, State Health Insurance Assistance Program and the name of your state, and it should bring up the name of that program and the website that you can access. Again, there's the Mental Health Part D website that I mentioned earlier. There are a few resources on this website that have not been updated in a couple of years. So you do want to be somewhat careful with some of the resources on this website to make sure that you're looking at the most up-to-date information. But most of the stuff on the main website is very reliable and has good information both for mental health consumers and for mental health case managers about the Part D program. You can also send specific questions that you have about the Part D program to this internet address, to partd@psych.org. That goes to the American Psychiatric Association's helpline, and they can answer specific questions that you have about Part D coverage of mental health medications. And the phone line for the helpline at the American Psychiatric Association is that phone number listed below, 1-800-343-4671. Medicare Access for Patients RX is another good website with some basic information both for elderly beneficiaries and beneficiaries with disabilities about the Medicare prescription drug program. I really like this website because they've really made an effort to keep the literacy levels at a manageable level so that people who may not have the best reading skills in the world can still access this website and understand the materials that are presented about the Part D benefit. For those of you who are in Missouri, the Missouri RX plan is the state pharmaceutical assistance program that covers prescription medications, that covers part of the copayment for Medicare Part D prescription medications for people in the state of Missouri. The last one is the Access to Benefits Coalition. The Access to Benefits Coalition is another website that's made a real effort to keep the literacy level of their materials very manageable. And the Access to Benefits Coalition has a lot of really good information for all kinds of Part D beneficiaries about the Medicare prescription drug program and how to sign up for a specific plan. So that's the material I wanted to present today. I'd be happy to take any questions that anyone has at this time.
Thank you. It's a wonderfully informative program, and we do encourage people to use the email questions for speaker link underneath the video window. We did actually have a question come in a short time ago, and she was looking for some clarity on what makes someone dually eligible for Medicare and Medicaid.
That has to do with their income level. People who are on supplemental security income would be eligible for Medicaid. If they also receive the Medicare benefit, then they would be dually eligible for both Medicare and Medicaid. Most people who only receive supplemental security income would generally be receiving only the Medicaid benefit. So most people who are dually eligible would be people with pretty low incomes, but who are receiving Social Security disability income in addition to their SSI, and who are eligible for both Medicare and Medicaid.
And is there a cost for Medicare Part D, or is it all paid for by the government?
Again, that depends on your income. If you're a full dual eligible, receiving dually eligible for Medicare and Medicaid, then the government will pay the premium for that Part D plan, and the government will pay for costs during the donut hole of prescription drug coverage that some higher income people experience. So under Part D, the only expense to the consumer for a dually eligible beneficiary would be those co-payments that some beneficiaries do experience. And in some cases, community pharmacies do waive those co-payments. So for some very low income people, it is true that there is no cost at all associated with their use of Part D.
All right. I do not see any more questions coming in, so I'd like to take this opportunity to thank you so much for your time and your expertise today,
Thank
Melissa.
you.
It was really a wonderful program. We covered an awful lot of ground here, so I hope people found that very useful to the work that they're doing out there. We do have another program coming up tomorrow. It's a public health approach, public policy approach to preventing mental illness and to promoting mental health, and that's Bruce Horwitz, who's on the faculty of the University of Missouri-Columbia and also on staff here at the Missouri Institute of Mental Health. They're presenting at this same time at 1:30 in the afternoon Central. So if you'd like to join us for that program, we encourage you to do so. We'll leave the CEU application open for a little while. We'll also send that link to you in an email if you'd like to apply for CEUs to today's program. And any other follow-up information that you'd like from us, please let us know. We'll try and include some of those websites that you had in our follow-up email as well, because a lot of people find those useful in their work as well as good resources for them. So again, thank you for your time today, and Melissa, thanks for yours.
Thank you.